Hello and welcome to this special episode of our Pretty Talk podcast. Today we dive into one of the most crucial areas in modern intensive care, that is sepsis management. To guide us through this important topic, we are honored to be joined by one of the most influential leaders in global critical care. It's my privilege to introduce Professor Andewal, President of European Society of Intensive Care Medicine, intensivist at Ghent University Hospital in Ghent, Belgium, senior investigator at the Flanders Research Foundation. Professor Anne, thank you for being with us. We're excited to hear your perspective. The stage is yours.
Thank you very much. It's a pleasure to be with you and to speak on a topic. Of course, as you know, sepsis, and as you mentioned, sepsis has many different aspects. So many different things we need to look at, and it will be my pleasure to talk on the specific theme of using and how to use antibiotics. It's a pleasure and an honor.
Thank you. Thank you
I
for
will
being.
now be sharing my screen to launch my presentation. So in the next 15 to 20 minutes, it'll be my pleasure to talk to you about continuous infusion. So this is not about choices of antimicrobials. This is not about doses. This is just purely about how we administer our drugs. And I will show you how this can have an impact on patient outcomes. So these are my disclosures. I've been doing research in this domain for quite some time. And I'm really happy to see this moving forward and finally bringing some solutions to the bedside. I think I don't have to tell you how important antibiotics are when it comes to the treatment of patients with sepsis. As already mentioned, indeed, the issues, the stakes are high in sepsis. We know that mortality rates, despite all the different studies that have been done, the different interventions, the early recognition, etc., still sepsis, septic shock mortality rates are 40 to 50%. It's lower for sepsis, of course, but there's still some room for improvement. And at the other hand, antibiotics, which essentially is the only thing you can actually do when you treat a patient with sepsis, the only thing you can do is treat the infection that is underlying that is the cause of sepsis, is what we do. And we use a lot of antibiotics in our ICUs. And the sad thing is that it is linked to antimicrobial resistant development, but also that a lot of this use is inappropriate, as in there is a better alternative, unnecessary, as in, the patient doesn't need antibiotics anymore or doesn't need 2 or 3 antibiotics to counter the same pathogen. Or the treatment that is administered is the right drug, it's the right dose, but it's not the right way how it's been used. And this is where continuous infusion and infusion strategies overall for antibiotics come in. Now, beta-lactam antibiotics, even though newer antibiotics are coming to the market, they often belong to the same family. They have been the cornerstone of antimicrobial therapy for obvious reasons. Wide spectrum, especially with the newer drugs coming to the market. Low cost, and this is where probably these newer drugs are the exception, but many of the penicillins and carbapenems that we've been using for a long time are low cost and also low toxicity compared to other drugs, especially for multi-drug resistant pathogens. If you look at colistin and glycoside, then the toxicity is significant. So beta-lactam use is therefore high. At the same time, studies have shown, I'll give you some data in a minute, that indeed the resulting concentrations in the plasma and also at the infection site is highly variable between patients. And we know that if you underdose, you're not only impacting patient outcome, but probably also enhancing the risk of antimicrobial resistance development. Now, for a long time, we have been thinking that the success of an antimicrobial therapy is determined by the spectrum, as in the spectrum should be targeted at the pathogen involved, and also making sure that the administration is timely, that you are not too late with your antibiotic. And this is how we've been educating people for a long time. Now, there's more to this. And let me walk you through the reasons why we need to consider also different aspects. We know that critical illness does have an effect on pharmacokinetics, the way the drugs behave in the body. And it's not only antibiotics, by the way, but specifically for antibiotics, we know that critical illness is associated quite often with a hyperdynamic circulation, increased clearance by the kidneys leading to lower plasma concentrations. But also other effects play a role, like altered fluid balances, patients receiving a lot of fluids, third spacing because of capillary leak, leading to a higher volume of distribution, again contributing to lower than expected plasma concentrations. On the other end of the spectrum, you may have situations where organ failure sets in, renal dysfunction, most importantly, because a lot of these drugs are cleared by the kidneys, especially the beta-lactams. And sometimes we make things even more complex when we add treatments such as RRT or ECMO or filters that also may impact plasma concentration of drugs. So it can go many different ways. And basically, we have no clue. We cannot see whether the concentration is high or low. When we measure, and this comes from one of the landmark studies in this domain from Jason Roberts, looking at a large cohort of patients, more than 350 patients, looking at concentrations of these different beta-lactams. Bear with me, if you look at the concentrations for all these different drugs, mid-dose and end of dose on the right hand of the slide, you see, just look at the variation. Don't look too much at the absolute numbers, but see the spread, the distribution of all these concentrations. All these patients were treated with the intent to cure the patient, and still we found that 1 out of 6 patients did not reach the most conservative target. A lot of debate is ongoing which target we should be using, I admit. We're maybe still in the dark at sometimes, but the minimum target that we all agree on was not met in many patients. So this is why in 2025 and the years to come, antimicrobial success will not only depend on the right drug, the right time, but also the dosing and the way it's been administered. And for the remainder of my talk, I will focus on the way we administer these the drugs. Let's go back to the basics of pharmacokinetics. This is a concentration time curve of an antibiotic or any drug that you would inject into a patient, and the gray curve. And you can see that dependent on the type of drug, the way they exert their activity is different. Beta-lactams, you can see here in orange, need to have as long as possible their concentration above a certain threshold, the minimum inhibitory concentration of a pathogen. So this is at the pathogen level. This is how you optimally treat an infection, or you counter a pathogen. For other drugs like aminoglycosides, as you can see here, it's different. Aminoglycosides, it's important to have a high peak over the MIC. So dosing strategies for beta-lactams, for instance, or aminoglycosides are quite different for good enough reason. So when we switch from intermittent on the left to prolonged infusion on the right, also you can see here that an extended infusion, so extending the infusion over a few hours, over 3 hours, results in this blue curve. So you had longer, the concentration above the MIC compared to intermittent is longer. And when you switch to continuous infusion, in red, this concentration is even above this target for, well, most of the time when the antibiotic is being administered. So clearly, prolonging the infusion does have an impact in vitro on the concentrations you get, and likely to impact clinical outcomes. There is evidence, and I'll show you that in a minute, that goes beyond these pharmacokinetic concepts that I just explained. Before we go into the evidence, let me just briefly again emphasize the terminology here. Prolonged infusion covers both extended and continuous infusion, compared to bolus infusion, typically, well, through bolus or say maximum of half an hour. Extended infusion over a few hours, typically half the dosing interval, for instance, 3 hours for Pip/Tas, and continuous infusion, or meropenem as well, and continuous infusion, you just keep the antibiotic running. How you do this, I'll tell you at the end. So why to do this? I already mentioned it. You want to improve outcome, at the same time reduce antimicrobial resistance, because you avoid these low concentrations that bacteria like to develop resistance. But also, I think it offers opportunities to treat multi-drug resistant pathogens where maybe the susceptibility is still there, provided high concentrations are being used. There is a solid body of evidence on the pharmacokinetics, so the theoretical concepts that I explained you earlier are actually now also confirmed in patients and animals first, but also in patients. Here you can see meropenem concentrations in both the plasma and the tissue in patients treated with the drug. On the left-hand side, it is the first dose that is being studied. On the right-hand side, the two figures there are the dose at 40 hours after the initiation. It's just confirmed you that both at initiation, but also throughout the treatment, you have at the tissue level better concentrations. And you can see in gray is the bolus dosing, and in black is the continuous infusion. And clearly, higher levels, not only in the plasma or continued high levels in the plasma, but also at the infection site. So clearly, also here, and this is important, of course, there is data to support its use because it does impact the concentrations at the infection site. So a number of studies have been done. This is one of the first that has been done coming from Jeff Lippman's group, Jason Roberts, looking at continuous versus intermittent infusion. A small number of patients, single center study, showing that when it comes to the pharmacokinetic targets, having your concentrations above the MIC for 100% of the time, so that means throughout the treatment, the drug level is above the target concentration, is much more likely to be obtained in continuous infusion compared to intermittent infusion. Clinical cure was higher numerically, not statistically significant because of the numbers, and survival also numerically different, but not at all statistically significant. But this triggered a number of other studies, and more particularly the BLING III study, which I will show you in a minute. Before going through the BLING III, which was the largest study on the theme up to date, I want to mention this study, the MERCY randomized controlled trial looking at intermittent versus continuous meropenem administration in a number of countries in Europe, Croatia, Italy, Russia, and Kazakhstan. Patients were enrolled, 600 patients in the study. As you can see here, 607 were randomized. Looking at the patient's characteristics, you can find them here. And you can see that, well, these are not patient characteristics, apologies. These are outcomes. This is the primary outcome, and you can see no difference whatsoever on this primary outcome. The primary outcome here, remarkably, was a composite endpoint combining all-cause mortality and the emergency of pan-drug resistance or extensively drug-resistant bacteria, so combined. Also, when breaking them up, this is just a little bit lower here, you can see that there was no difference in mortality, no difference in the development of pan-drug resistant bacteria. There are a number of things to consider, however. Remarkably, 35%, so 1 out of 3 patients roughly in both groups, the pathogen was not susceptible to antibiotics at baseline. So, of course, well, you can randomize these patients, but if the drug doesn't work for the pathogen, you're not likely to see any clinical difference, of course. So these studies, these patients should not have been in the analysis, if you ask me. And also a very difficult one, and this is, of course, typical of pathogens, multi-drug resistant pathogens, is that a lot of patients receive concurrent antibiotic therapy, 3 out of 4. And it's always difficult to tease out what the impact was of, a specific drug when many other drugs were administered to these patients. All right, so that brings me to the BLING III study, which I had the opportunity to also collaborate on. This was a multinational study, as you can see, some countries in Europe, also Malaysia here, and Australia and New Zealand were involved. Also the UK, very big contributor to the study. Published in JAMA in last year. This is the summary of the inclusion details. So 7,000, more than 7,000 patients were included. So this was really a gargantuan task. Patients with sepsis, mean age was 59, and 104 ICUs contributed. All-cause mortality was the primary endpoint, and patients were either treated with meropenem and PIP-TAS. Baseline characteristics, nothing really surprising. Betcha 2 score of about, well, just under 20, median and mean. So clearly, well, quite ill patients. And the types of infections involved, the usual suspects, pulmonary infections ranking first and abdominal second. So this seems to be the type of patients where you use these drugs in. Primary outcome, looking at the all-cause mortality unadjusted, there was no difference. The absolute difference was almost 2% lower mortality. In the, well, predefined, of course, adjusted analysis for severity of illness and other factors, there was a small, but 2% decrease, absolute difference in mortality in these patients, so 25 versus 27, roughly. Secondary outcome, clinical cure at day 14, was statistically significantly higher in patients receiving continuous infusion. Looking at some sub-analyses, when you look at mortality, whether the infection was pulmonary or not, which drug was used, the age of the patients, the sex of the patient, and the severity of illness, you can see here that everything goes into the same direction, so quite consistent data throughout these different patient categories. These data were in the same issue of JAMA. There was also an updated meta-analysis with the BLING III data also added to this. And this, of course, had also the MERCY study that I mentioned earlier in it. 17 studies, more than 9,000 patients, so huge body of evidence, I would say. And I challenge you to find a lot of themes in intensive care, things we do regularly, where you have data from 9,000 patients to inform clinical practice. So these are the details, and on the right-hand side, you can see the summary, and indeed, independent of how you look at it, there is a statistical significant impact of continuous infusion over intermittent infusion in these patients. I should not say continuous, I should say prolonged, because this was the analysis that was done, although understanding that the bulk of the evidence comes from the BLING study, where the way of administering the drug was continuous. Looking at specific secondary outcomes, ICU mortality, statistically significantly lower in patients treated with prolonged infusion. Clinical cure, it's the same. It's an advantage of prolonged infusion. So I think this all aligns well. The number needed to treat, and it's also important, of course, you need to treat 26 patients to have one patient extra surviving. So that is, I think, quite strong evidence supporting at least my answer to this question: is it new standard? I would argue yes, it is. There are some things to understand and to look at when you do this. I think it's imperative that you use a loading dose. A loading dose is essential to get your concentrations up high, either with extended infusion or continuous infusion, as you can see here. If you do not give a loading dose, then you see it takes hours, up to 8 or 9 hours, before you get the same concentrations as compared to when you would do a loading dose first, immediately followed by a continuous infusion, and that's how we approach it. There are some things to consider. Stability is an issue. It is variable. I think it's worth exploring with clinical pharmacists, if you have them, to see if it's okay. There are some impacts of which solute, whether you use glucose or saline, the temperature at which it is stored, but also at which it is administered. So temperature in the ICUs could have an impact. So you need to check it. For the most of the drugs we use, providing that you use the right concentration and the temperature is not extremely high in the unit where you work, that should be covered for meropenem, piptaz, and ceftazidime, albeit that there may be different suppliers, different manufacturers for the drugs, so it needs to be checked. It's a clear no for amoxicillin clavulanic acid, because you get this yellow, grayish discoloration, brownish discoloration, and you do not want to infuse that in your patient for sure. Dedicated line, yes, that's one of the issues that people sometimes bring up. I do think that that is, in a way, you can overcome this when you use extended infusion, and then you can use your line for other drugs in the meantime as well. These are some data that we collected some time ago on the different manufacturers of the drugs, and the stability, also depending on the concentration that was used. So you can see that higher concentrations are overall tend to be less stable. So if you dilute them enough, then it stays well above the 90% stability in these patients. How do you do it? Well, we use a syringe pump to administer the drug, low priming volume, especially relevant when you use extended infusion and you use one of these infusion pumps. You need to understand that the priming volume can be significant, and up to, if you use like 100 ml bags, a residual volume of 24 ml would mean that a quarter of the dose may stuck in your infusion tubing. So you don't want this to happen. Interesting enough, Nicole Huntveld from Rotterdam, she looked also at this sustainability and found actually that when you use piperacillin in a continuous way, and this allows you to prepare one infusion bag because peptaz is in the right circumstances stable enough to be administered over 24 hours, you actually also have less waste. So is this now the final answer? Is there anything else to consider? Well, a few things. The question, the jury is still out there, whether extended or continuous is to be preferred. There is some interesting data suggesting that also pharmacokinetics may change in continuous infusion, but that is something that we need to have more information on, and for now doesn't, of course, question the clinical impact that I've just shown you. Do the pharmacodynamics also change? That could be the case. And again, very interesting work that we may learn more of in the next years. And the last thing, and the last slides, I do want to mention that, of course, higher PK/PD targets, so that the higher you want to target, continuous infusion or prolonged infusion may not be the only answer. This is a hypothetical, this is a simulation where you have different degrees of creatinine clearance and different levels of susceptibility, going from an MIC of 1, 4, 8, and 16. And here you see clearly that with lower MICs and even high filtration rates, that you will get there with the standard doses of peptaz in this case. You can see as the MIC goes higher that you need to dose higher, but even higher doses may not be still good enough to get adequate concentrations and higher creatinine clearances. So we're still out to trying to find out how the higher targets and continuous infusion and the right dosing strategy all fit in together. This is also still a matter of debate. Which targets do we need to aim for, and probably for a maximum of bactericidal effect, higher concentrations, that's where we should be aiming at. But I don't think that should be keeping you from using continuous infusion or extended infusion in the meantime, while scientists try to figure out what is needed. So in summary, 2025, we know it's not only about the spectrum, about the dose, and about the timing, but also the administration is important. So yes, beta-lactams remain one of the cornerstones, and it's determined also by the way we administer. The evidence base is quite solid, I think, now supporting prolonged and more specifically continuous infusion. No safety issues have been identified. I didn't mention this. I didn't go into detail on that, but it is important to understand. Loading dose, if you do this, always do a loading dose. There are some questions that remain, and this is, of course, something that is relevant in any theme in intensive care, in any domain. And I think this is just one of the different ways that in a stewardship approach, trying to go for personalized precision antimicrobial dosing, this is really one element in that strategy.